enhanced recovery after cesarean section is the next topic. And then we'll take the questions after that. Thank you. Umeona hiyo cameras in the camera is activated every time the guy walks in. Cameras might never go on.
Thank you. So my next presentation is on enhanced recovery after cesarean section, where I'll present a summary of the evidence and give our institutional experience. So enhanced recovery after cesarean section is a perioperative care bundle, and the idea is to accelerate recovery by reducing surgical stress. And it's not a new concept. It was started by the colorectal surgeons, some Danish colorectal surgeon called Henrik Henlet in 1990, and it was now taken up by other specialties. Unfortunately, in obstetrics, we were late to the party. Until 30 years later, that's when people started incorporating ERAC protocols, and the first ERAC guideline was in 2019. But since then, we have actually high-level evidence from systematic reviews that ERAC in cesarean sections reduces pain, has fewer complications like surgical site infections, patients have faster recovery, there is better bonding between the mother and the baby, patients report higher satisfaction, and there is early mobilization. Taking a deep dive into the evidence, one of the most robust evidence is from this systematic review, which looked at post-operative pain. And if you look at the forest plot, if you look at the diamond that gives the summary, it favors ERAC. And the mean difference was found to be 1.23. That means the pain score was less by 1.23 in those that went through the ERAC. Now, probably somebody may be wondering, is this clinically significant? But actually, studies have shown that the minimum difference in pain score usually is 1, so anything more than 1 is considered to be significant. So this appears to tell us that ERAC patients would tend to have less pain. Why is this important to the patient? We know that patients who are in pain will not mobilize and may have at risk of getting VTEs. They're not able to bond with the mothers. We have evidence to show that mothers with poorly controlled pain are 3 times at risk of postpartum depression, and also because of the pain, if it's not well controlled, 2.5 times risk of patients having chronic pain. But alas, what happens in many of our wards is what is depicted in that cartoon. We underestimate and undertreat pain, okay? And so a mother will be brought flowers, a mug of uji and things like those, and you see she's doubling up in pain, which I think is what she needs. And in my view, pain management after surgery is more important for cesarean even than other surgeries. Why? Because think about it, a hysterectomy, the only thing that patient needs to do is recover. But for C-section, you want her to nurse the baby, to change the diaper, so we really need to think about pain. Our protocol follows the entire continuum, and I'll talk some of the elements that I think are important. In the preoperative, we first start with explaining the procedure. So when we do our consent, we don't just tell the mom that we're going in for a C-section. We explain to them why we are having the C-section. We explain the management plan, including our pain control plan. Because as you'll be seeing, as I'll be talking about later, post-operatively, it is largely oral. And so sometimes patients would be like, I've not been given the medication for pain. So we explain to them what is expected. We also discuss that we want them to feed early. And we moved away from what we used to do previously, which was not scientific, which was NPO from midnight, because that has been shown not to be scientific at all. And so it is actually recommended that 8 hours before solids is good enough, and clear fluids 2 hours. There's actually robust evidence to this effect. And so for our patients, so for example, if a patient is having a C-section, an elective C-section, maybe at 10, she can have water, take water till morning, and there's good evidence to show that that is actually safe. Intraoperatively, we use spinal anesthesia, and I think I'm happy that Kigondu mentioned something I didn't know about Dr. Kihara's contribution to this. So nearly all our patients have spinal anesthesia. We know that 60% of patients under spinal will have hypotension. So in our protocol, we give a co-load, not a preload, because if you look at the evidence, it's actually shown that it is not scientific to give the preload that is given in the ward, because there's distribution. That happens within 30 minutes. So if you've given it in the ward, within 30 minutes, you have less than 15% of this fluid in the system. So what is recommended is you give a co-load, because when you give a co-load, usually it peaks within like 15 minutes, which is the time that this spinal hypotension is coming in. So the co-load is given in theater and rapidly. It is also recommended, based on evidence, that you proactively manage hypotension rather than reactively. So we use vasopressors, and phenylephrine is what we use. Our surgical technique, we have a uniform surgical technique, whether it's the medical officer who's doing the cesarean sections. And so based on evidence, we use the Joel Cohen technique, which has been shown from Cochrane reviews to be faster, less pain, and less postoperative fevers. So for example, if we have new medical officers joining our facility who are not interns that we've trained, before they start performing cesarean sections, then we have to do a couple of them with the consultant, so that we're able to make sure that they can follow the Joel Cohen incision. We do not close the peritoneum, because from evidence it's been shown that that causes more pain. Neither do we exteriorize the uterus, because again, if you look at the evidence, it appeared to show that when you exteriorize the uterus, there is more nausea and vomiting. So we only exteriorize, of course, if there is an extension or difficult achieving hemostasis, but routinely the uterus is repaired in situ. The verdict is out that antibiotics are effective when given before the incision. So our drug of choice is cefazolin, and it is given before incision. So so one of the things that we realized initially, the anesthetist was putting it in the fluid, which is running in theater. So by the time you're making the incision, the whole 2 grams is not in the system. So now we use the WHO patient safety checklist, so that before the surgeon makes the cut, the anesthetist says that the antibiotic has already been administered. And we don't use postoperative antibiotics. In terms of skin prep, based on evidence, chlorhexidine alcohol solutions have been shown to be superior to iodine solutions, because iodine is inactivated by blood, and chlorhexidine has a longer residual effect. So the recommendations appear to favor chlorhexidine alcohol compared to iodine. We also do a vaginal dosing with iodine solution. So when the nurse is inserting the urinary catheter, they do a vaginal dosing, because there's evidence that actually, in fact, it's one of the WHO recommendations that it should be done. Now, the evidence is more for emergency C-sections where the membranes have been ruptured, but we realized that having this distinction was causing an issue. So some of them were, it's been done and it's not been done. So now we do it routinely. When the catheter is being put, the nurse does the cleaning. Of course, we know now from evidence that there's no role of shaving. In fact, shaving increases exercise, so we do not shave our patients. I think the other most important is the fourth one, intraoperative nausea and vomiting. And if you look at the evidence, they recommend that you ideally should use 2 antiemetics with 2 different mechanisms of action. And the ones that are proposed by most guidelines is use of dexamethasone and either ondansetron or placid. So dexamethasone is something that we use routinely, and dexamethasone has additional advantages compared to these other antiemetics, because it's been shown to be very effective in the late post-op pain, reducing pain, and it also has antiemetic functions even after surgery. So all our patients, and this is given before the procedure, before doing the cut, so we give ondansetron and dexamethasone. This, I think, is the most important slide. Our pain approach is multimodal, and the cornerstone that we use is intrathecal morphine. So we use 100 micrograms of morphine in the bupivacaine during the spinal anesthesia. And look at the dose, it's very low, 100 micrograms. But this is actually what is recommended. It's been shown to be quite effective. I'll be talking about the mechanism later on. So this is the cornerstone. And the beauty about this is that this has a long duration of action. And once these patients are on this morphine, from our experience, they wouldn't even need any postoperative opioids. Then, as I've said, it's multimodal. So we also give paracetamol and an NSAID, either Kitase, ketorolac, or sometimes diclofenac. For those patients that we cannot give intrathecal morphine because we've used general anesthesia, say a patient with preeclampsia, with thrombocytopenia, then the evidence recommends that you either do a tap block or you do infiltration of the incision. Now the tap block, the challenge of course is the technique. So in our facility, for C-sections done by the rest of the team, most of the time what is going to be used in these cases is infiltration. And that is just a slide showing how multimodal analgesia works. And if you look at the middle part, the dorsal horn, that is where intrathecal morphine acts. Because intrathecal morphine, it is hydrophilic, so it remains in the CSF. And if you look at the dose, I talked about 100 micrograms. Studies have shown that there's a ceiling effect, that you don't get more analgesic benefit with more than 100 micrograms. Because what happens is that it saturates the receptors. And so you're tackling pain both from centrally from the brain, at the dorsal horn, and also peripherally using your NSAIDs. And so this is actually now what helps to make sure that these patients are comfortable. And so the evidence is clear. And if you look at most recommendations, they actually recommend use of intrathecal morphine. But why is it not used? It's a safety concern. And so let's look at the mechanism of this. So the most feared issue, of course, is respiratory depression. And this usually has two patterns. There is the early and the late. So the early happens immediately, within 30 to 90 minutes, and it's because of rapid vascular absorption of this morphine. The late now happens later, because what happens is that the morphine is in the CSF, and as the CSF is traversing, so it goes to the brainstem, then reduces the respiratory drive. And clinically, these patients would present with bradypnea, the respiratory would be low, they would have irregular breathing, they'd be sedated, and have SpO2s that may be low. But what does the evidence say? Interestingly, it's been shown that this is quite rare. And this is the most quoted evidence. This was a systematic review of 18,000 patients, which showed that the incidence is 1 to 2 per 10,000. And they showed that there were 0 naloxone events. Basically, none of these patients needed naloxone. The last that I've indicated there, 0 fatalities, that is data from the American Society of Anesthesiologists, where they looked at 1.2 million claims for maternal mortality in litigation, and they didn't find any that was attributed to intrathecal morphine. And so, what is the take-home message from this is that what we feared as respiratory depression, yes, we are okay to be concerned about it, but the incidence may not be that high. However, this is not a carte blanche for us to say that let's give morphine and forget about it. Because of that risk, the recommendation is that you need to monitor, and in our protocol, we borrowed it from the Society of Obstetric Anesthesia and Perinatology, where they recommend that you risk stratify your patients. So all our patients, we identify if they're high risk or low risk. And these are the ones from evidence that have been shown to be the risk factors. If a patient is obese, if she has preeclampsia hypertension, is on magnesium sulfate, or for example, if you've had to convert to GA. Once we do that, we now say patient is high risk or low risk. And the low risk, this is now our monitoring protocol, where we monitor the respiratory rate and sedation score every 2 hours for 12 hours. This is actually the recommendations based on the evidence. Those that are high risk need more monitoring. So usually it is hourly for 12 hours, then 2 hourly for the next 12 hours. Now, we've entrenched this in our documentation so that when we do our notes, we don't just say monitor as per this. So we actually indicate, what should be monitored and how often. A challenge that we experienced was that this monitoring was being documented in the KOGS, and so sometimes it was not being done, or something was being forgotten. So that now made us come up with an obstetric monitoring chart. So this is used for all our patients, where these specific issues are, have to be documented. So it becomes easy for us to audit and see if it was actually done within those timelines. Postoperatively, this is something that we are quite proud of. Virtually all our patients are on oral medications after C-section. We do not use any parenteral analgesics, but sometimes we use them for those that have breakthrough pain. But as I'll be showing in the subsequent slides, we found that our pain control is actually quite good. The game changer here was following the WHO recommendations of by the clock. And so our medications usually, our nurses usually give it by the clock. So if we've done a C-section now, and we've given IV paracetamol, then we indicate that the next dose of paracetamol should start within 6 hours. So in our notes, we actually indicate to start at 6 p.m. The other thing that we found to be also useful, instead of writing TDS, because we found that when we did that, the interpretation was TDS is what? 3 times a day. And so we indicate there it should be 8 hourly. But we use maximum doses. So for the paracetamol, we use 1 gram 6 hourly, and when we use ibuprofen, we use 600 6 hourly. And we found that our patients have had very good pain control despite not being on parenterals. Just a brief summary of some of the data that we looked at. We looked at this end of last year. 4,272 patients have gone through our ERAC protocol. That was as per December last year. And an audit that we did of 121 patients showed that almost 96% compliance. As I said, we have a checklist. So for all patients, it is ticked. Was ondansetron given? Was this done? And so we found 96%. Almost 92% of cases, morphine was used. And we found that when we did an audit of these patients, 94% were able to achieve golden hour breastfeeding, meaning breastfeeding was initiated within 1 hour. What did the patients tell us? So we did an audit of 100 patients to look at their satisfaction. And we used a validated tool, the OBS QOR10, which is a validated tool for looking at recovery. And 92%, our overall score was 92%. Now, if you look at literature, they say I think anything above 85% is considered to be good. So 92% satisfaction, we were quite happy with that. This tool looks at 10 domains. The two main ones that we also looked at are pain and nausea, which are also captured. And what I've indicated there is the median. Pain control was 9 over 10. That doesn't mean a pain score of 9 over 10. It means that the median patients who say that they are comfortable with pain, 9 out of 10 patients. Now, for nausea, this is where, at least from this small data, we were quite happy with. The median was 10. Patients saying that they are comfortable, they've not had any nausea. And we found that the biggest game changer for us was our introduction of the dexamethasone, as I've talked about. Looking at the numbers, we found that our ERAC protocol was also good for the pocket. We did an analysis of the average cost of the medications post-op for patients before the ERAC and after. And we found that before ERAC, the average was 4,167, and now it is 1,718. Basically, we itemized everything from the morphine, the gloves, and everything. And so this represented a 59% reduction, which comes to almost 2,500 per patient. Now, it may seem like not a lot of money, but when we did the math, I was actually quite surprised. This is over 4 years. It came to 10.5 million over the past 4 years. Because we counted, for example, if it's post-op, maybe tramadol, the nurse wears gloves, uses a syringe, we are using post-op antibiotics and things like those. So basically what this told us is that, in the summary of this, is that we had good compliance of our ERAC protocol. Patients were happy with it. They had less pain, less nausea, and it was cheaper. For those that may be considering adopting an ERAC protocol, the first most important thing is multidisciplinary buy-in. This is not something that you come and railroad to your team. And I've found, especially in our settings where we work maybe with, we don't have an anesthesiologist, so I needed to sit down with my anesthetist, the clinical officer anesthetist, a nurse anesthetist, and take them through the science, and so now you're able to onboard them in. Then, of course, you need to have training. I think checklists are very important, and so for us, we have routine checklists for all patients to see if all the elements have been captured. Patient education needs to be done preoperatively, and regular audits and feedback. What I've just presented here is an audit, but we are in the process of collecting data, and I'm hoping maybe by next year I'll be able to present this, where we want to look at individual issues for all these patients. How many patients needed to use tramadol? What is our SSI rate? And we want to identify maybe another institution that does not follow the ERAC protocol, and so we do a prospective, then we can be able to compare. Of course, this needs to be adapted based on the contextual evidence. You know, if, for example, if there's an issue with the nursing, then you need to see if that can be addressed. And so I think in closing, this is a team sport. You can't do it alone. And those are the beautiful people that we get to do this work with. And so you'd have to have everybody on board, including even the porter, the guys from the hospitality, so that, you know, a patient has come from theater, we make sure that our patients start feeding 2 hours. 2 hours post-op, we start oral sips. By 4 hours, they're on full diet. So you need to make sure that everybody is on board. We were recently honored to have our ERAC protocol receive an award in the Africa Health Awards Summit. And the biggest win we found from this is from this shared learning and discussing with colleagues. We now have a hospital in Accra, in Lagos, and one in Pretoria, who now borrowed from the ERAC protocol and tried to contextualize it to their settings. And so we hope through discussions such as this, people may see what aspects that may be applicable, and maybe you may consider including them in your care of these patients. Otherwise, I think that's my last slide. Thank you very much.
That was an excellent presentation, and we'll be going in for tea. Online, you can join us for tea, but in the meantime, we want to address questions to Daktari. Daktari has made 2 very good presentations, and I think they are very relevant to our situation today. So, online, any questions? I see you've been following. Just unmute and ask, and then we'll come to the floor. Is someone asking a question? There are very many people online. All right, as the online community thinks of questions, then we can have questions on the floor.
Thank you, Dr. Kimani. That's an excellent presentation. My question or my sentiments is, for the ERAC, it's clear that we should not use antibiotics if it's given, cefazolin is given 30 minutes before. But unlike in your place where the training has been consistent and your anesthetic team is on board, in our public facilities, we once attempted, and the exercise that came was so enormous. And I was linking it to, first of all, we've not been able to achieve 1 bed, 1 patient. We still have patients sharing beds. And so for this antibiotic coverage, I think it should be individualized as per the hospital, the environment, and even the training, the workload, and all that. Similarly, there's this other issue about shaving. It is clear we should not shave, but there are patients who come. I don't know whether in your facility you've been able to integrate the antenatal, they do it at home, or what happens, because sometimes there's no place to even put your incision. What do you do in such a situation? Thank you.
Dr. Tungani has a question.
Thank you, Dr. Kimani. I feel like we should benchmark with the Consolata from your 2 presentations. Now, I have 2 questions, probably to you and also to the gallery. And the first one is on wound exposure. We know from science that 48 to 72 hours is the recommended time. And where the controversy comes is when does the patient shower? Because oftentimes you'll expose the wound and allow the patient to shower only for you to see them 2 weeks later in your clinic and they have not showered because they were told by the nurses. And then you actually start to doubt your own science. So I would like to hear your experience and probably from the rest of the team. The second question is a bit of your presentation, but it's because you mentioned the KOGS. I've worked in a facility where the KOGS and the doctor's notes is one document, and I felt like that promotes team cohesiveness and continuity of care. So I don't know what is the experience of the rest of the team. Thank you.
Well, those were very, very good presentations. Number one, I'm actually a beneficiary of the NTS training and the ERAC from your facility as a patient. He delivered my daughter. So I really saw it firsthand, and I was actually very surprised where the antibiotics, Daktari, where am I not given IV antibiotics, IV and analgesics, where I am on analgesics. I'm a big beneficiary, and I can tell you it works. I had a very comfortable time in the facility. I was eating within 4 hours of the cesarean section. So this is commendable and worth emulating. I think if Ghana and Accra come in to benchmark at your facility, then it's only fair that we local hospitals also come and benchmark and copy what you're doing. Another way in which I've benefited from this Consolata, the NTS and the ERAC training, is that we have had a spillover of some of your interns in our private facilities, and they actually are cut above the rest because they have very good communication skills, especially the closed loop communication. So good job, Daktari. My question is, how did you change the culture and attitude in the older staff, actually the older nurses? Because I find this cohort to be very resistant to change. So how are you able to change their attitude and culture in doing things? Otherwise, good job, Daktari. This is worth emulating.
Thank you, Dr. Kimani. I equally work in a low-volume hospital, and I've tried. Well, we've not come up with those checklists and the documents and all those like done. But I've tried in terms of not prescribing post-op antibiotics, and it's working. So I guess I'll continue on the same and probably also meet up with the whole team and try to come up with such documents and insist on following them through. The first topic you presented on, although I missed a bit of it, but I'm just discussing with colleagues. This teamwork business in public hospitals, kwa ground vitu ni very different. And I don't know whether you've ever worked in a proper public hospital where most interns are chaotic. In terms of they might just not show up for work. In terms of reviews, they'll just lie. Then you find you're in like a department for consultants. You don't get to meet, you don't get to discuss. It's very difficult. The nurses, most of the time, they really want to absolve themselves from issues. It's either the consultant's problem or the intern's problem. I really don't know how to. I'm very lucky I don't work with interns because I don't know how I would have handled such, So maybe you can comment on that. And it's not all interns, but we are really getting a problem.
Thank you, Dr. Kimani, for that wonderful presentation. I think Dr. has inspired me to comment because I work in public health system, and we discuss a lot of things with Dr. Kimani, somebody working with a functional system. What I can say is that it's possible to foster teamwork, even in the public sector. We work in a very high volume facility in Nyambene, in Maua, and the staffing is very low. It's a very low staff are stretched. But what I found is that there are a few things that we have started that have actually fostered that teamwork. And some of them were born out of the MPNDSR framework. So having those weekly meetings where we discuss the outcomes without any blame has actually shifted people from blame to actually appreciating where the gaps are and now being proactive in patient care. So I think as MPNDSR gets entrenched, I think it's making impact in the public sector in terms of collaboration. Because even where there was blame, is the MO, is the what, but you see, you go back, you find, what about you guys? You got this patient all time. So when you see there are gaps across the board, people now are able to actually take the responsibility and say that, okay, we can now work together. Because we are struggling a lot with that. When adverse outcome happens, you say, we call the MO didn't do this. But now when you actually discuss those things on a weekly basis, people start appreciating that it's actually across the board, and now it becomes a more strengthened team. So slowly, I think even the public, we are going to change. And then you see the visibility when you do the county ones. Every now when you're doing from private to everywhere where it happens, it's a private hospital, you see the gaps. It's a public hospital, you see the gaps. And this, from now, the chief officer is there, the director of medical services is there, it's an online forum. You find that when questions are asked, the truth has to come out somehow. So I think we are going somewhere. It may not be very easy, but there's change that is slowly coming in. And I credit this to a large extent to the MPNDSR framework and the awareness that is now coming. Thank you.
Thank you. Now, antibiotics. When I was preparing this presentation, you know, I carried my helmet because I anticipated. I'm happy at least I have not gotten as many stones as I was afraid I would get, because this is something that is quite emotive. And you know, we always talk about qua ground and things on the ground. But my view on this is that let us remember that, you know, we are scientists. So what does the science tell us? Now, coming from basic sciences, the biggest thing that protects against surgical site infections is having an effective antibiotic before the introduction of the bacteria. That actually is the biggest. So that means that if you've not given your antibiotic pre-op, whether you give ceftriaxone, meropenem, or whatever for 5, 10, 14 days, you failed to meet that critical window. And this is actually based on robust evidence. There are actually Cochrane reviews that have looked at this. And it's been shown that usually once a patient has gotten this, then there is no role for post-operative antibiotics, unless you have other markers of infection or other reason to suspect infection, okay? And so if you look at the evidence, surprisingly, there's actually evidence from LMIC settings such as ours. There's a good, maybe we can even share it in the group, I'll share it. There's a good study that was done in Nigeria and another one in Tanzania that looked at low resource settings. And they actually demonstrated, it was a randomized control trial, that there was no difference in the SSI rate in those that received post-op antibiotics and those that did not receive. And so the message that I'm giving is that not that there's no role of post-op antibiotics, but based on the science, what is important is pre-op antibiotics, and probably the other adjuncts that can help us to reduce the use of post-op antibiotics is some of the other evidence-based things that we've talked about. And these are things that I think, in my view, are low-hanging fruit. Chlorhexidine alcohol is not expensive. Iodine wash, is also not expensive. But for patients who are at risk, maybe the meconium, maybe the false-bending liquor, for example, certainly you would want to give antibiotics. Studies that have looked at post-op antibiotics actually looked at 48 hours. So even this 5-day, that is not based on any science at all. And so, there's no role. You might as well just, give the patient a glass of water. There's no difference if you didn't give the post-op antibiotic. So the message that we're giving is, of course, contextualized, but let us try to make sure that the antibiotic is given pre-op. Shaving, again, the evidence is clear that actually the risk is significantly increased with shaving, okay? And so of course, there's a concern of now what do you do when you need to make an incision, and there's the hair is all there. And so the recommendation is, just make the incision. It's not like it's stopping you from anything. The only challenge, of course, is there is discomfort when you're removing the dressing, especially if you're using, the strappings that we use. But if you weigh, you don't want to put these patients at risk of SSI. So this one, it is clear that there's no role of shaving based on the evidence. And in our experience, we don't do that. Somebody talked about wound exposure and shower. Again, there is no robust evidence, at least to the best of my knowledge, that I've seen. But mechanistically, if you look at wound healing, there's no reason why a patient should not shower after 3 days. Now, does this impact on SSIs? I don't know. But in our patients, once we remove the dressing, they go take a shower. But probably, maybe that's something we want to look at. But there's no evidence for this. Now, something else I'll mention about shower. There's some low-quality evidence on role of patients taking a bath before surgery. So this, we've also included it in our ERAC protocol. And the bath also, we inform the patient on how to take the bath. Because what needs to be cleaned is the hardest part to be cleaned. You can imagine a gravid mom getting where you'll be making the incision. So the nurse comes, tells the patient, we'll be having the C-section this morning, so please take a bath, make sure to clean the lower part of your abdomen. KOGS, that was mentioned, I couldn't agree with you more. And in fact, when we now embarked on an EMR, ours is continuous. And it's actually been shown that it prevents that fragmentation, so that when I'm coming to do my notes, I see what the nurse has indicated. And so that has been quite good. NTS training, I think a comment that was made, we are very proud by even guys who've come, from our facility. I was talking with one of our colleagues here who happens to work with one of a medical officer who we had worked with. And we're quite proud when we get, the feedback, because these are things that are not explicitly taught, but I think are quite important, which now comes back to what one colleague has mentioned about teamwork in the public hospitals. I agree, it may be difficult. I have worked, before my residency training at Aga Khan, I worked at Kapenguria District Hospital, and I don't think it gets more remote than that. And it was difficult, but we can't give up. So I think it's for us to do the little that we do to try and change culture and attitudes, which is what somebody else mentioned, changing attitude and culture in especially the older cadres. It is difficult. But I can tell you, from my experience, it is like gaining weight. Okay, you do not realize that you've gained weight. You just wake up one morning and you find that your belt, you've moved one hole. So cumulatively, or like growing hair. So I think it's just consistency, and once that is done, then you'll be able to, to see the benefits. And when we look at the team, I think the first, maybe which will be my closing remark is, multidisciplinary buy-in is important, okay? And when I started this ERAC protocol, the first thing was, we can't give antibiotics post-op, the SSIs will increase. And so I sat down, took the team through the evidence. We can't make sure that we can't just give patients oral meds. And in fact, now when we did a debrief later, the team, even the nurses, were actually happier because now their work is very little post-op, because they just need to make sure that they give these medications. I think the final thing that I will mention is that I think we are the ones who are taking care of these patients together with our teams. And I would probably recommend that it would be good for us to make sure that the rest of our colleagues are also onboarded, because we are the ones who understand the science. And so once we do that, then we'll be able to bring them on board. Based on the experience that we've had in discussion with other colleagues, we are planning on having a reproductive health symposium in a couple of months, and we'll be sharing that invitation. And it's not a conference, this is a symposium where we would wish to have the other people in our teams, the anesthetists, the nurses, and the purpose is not even presentations such as this. We want to come and have shared experiences so that Daktari tells us in Kigumo, we give antibiotics for 5 days because of this. Then we discuss, for us, this is what we do. And so maybe through the KOGS, we'll be extending an invitation it's something that we are discussing with also the team in the county so that we can learn from shared experiences. Otherwise, thank you very much, and KOGS, thank you for this platform. Let's continue doing better for our patients. Asanteni.
One more question. Are you giving tap blocks every CS patients?
No. So
how do you do?
So for tap blocks, the evidence is, if you look at the multimodal analgesia that I put, tap blocks works at the peripheral nerve, and intrathecal morphine works at the dorsal horn. So if you've given blockage at the dorsal horn, you don't need to give the tap block. Now for patients that you've not given intrathecal morphine, say you've done under GA, those are the ones that it is recommended that you give a tap block or infiltration. And it's not using the lignocaine, you use bupivacaine. Now, the issue is the tap block because of the expertise, and it is not as benign or as safe. So like in our facility, I'm the only one now who's able to do that. And now we do it under ultrasound guidance. So what we do now for the rest of the patients, because I'm not the one who does all the C-sections, what we use is local infiltration. And if you look at the data, it's actually been shown that if you don't use intrathecal morphine, either use a tap block or infiltration, which I think is something that is easy, can be done by even the medical officers. So I would not recommend having tap blocks done routinely, especially, I mean, I know of complications that have arisen from tap blocks. So even a wound infiltration, I think, would be quite good. But if you've used intrathecal morphine, there's no need, because it does a good job at blocking at the dorsal horn. And I think if there is one takeaway that I would wish many of us to take, is that, intrathecal morphine, that the evidence is clear. That's what we should use. This business of fentanyl and whatnot, if you look at the pharmacokinetics, it's not effective. And when we've looked at the safety data, there's really no reason for the whole concern or hullabaloo. But if you've used that, then you don't need a tap block. Yeah. How we prevent adhesions. So one of the things that when we are training our colleagues, we talk about is the essence of a surgeon. And that's one thing that all my medical officers and interns will say. Hands of a lady, heart of a lion, and eyes of a hawk. Eyes of a hawk to see bleeding, heart of a lion, when you see bleeding you don't run away, but hands of a lady. So we find that most of the things that also contribute to adhesions is when tissue is manhandled. So that's one of the things that we use. So, and that's why even for our cesarean sections, all our team is credentialed. So if we have the medical officer, new medical officer coming in, we have to perform a C-section with them, then we're able to make sure that we see how there is handling of tissue. In terms of other barriers, we do not use, I know there are institutions that consider using other pharmacological barriers, but I feel one of the most important things is just making sure that you follow the Halstead principles of surgery. Achieve hemostasis, you make sure that you handle tissue adequately, and 100 micrograms, which is very little. One vial, I think, has, is it 50 or what? I can't remember. So that
given at spinal.
Yeah, it's given at spinal. Okay. So the anesthetist dilutes it, then puts it in the bupivacaine. So actually the cost, you'll be surprised, the cost of the intrathecal morphine for one patient, when you divide, it comes to 4 shillings. 4 shillings. That is as at 2 weeks ago. Yeah, so it's 100 micrograms. And the reason why we use a low dose is because it is targeting the dorsal horn. So it is actually has been shown to be more effective than even giving parenteral, 10 or whatever. Yeah.
One more. Are you using chlorhexidine for vaginal douche?
So if you look at the evidence, they actually showed that it is equivalent. You can use chlorhexidine or iodine. But the issue with chlorhexidine alcohol, of course, is irritation of the vaginal mucosa. So that's why we use iodine. And safety studies have shown that there's no risk to the baby with using iodine. So based on the evidence, you can use any, but chlorhexidine alcohol would be irritative to the vaginal mucosa. So in our case, what we use is iodine. Yes, now urethral catheters. So I know in some settings, the catheter is removed. I remember like in Aga Khan, we used to use an elaton in and out. Yes. You just, and after the surgery, you remove it. And that is actually what is recommended. And that's what we were doing initially. But we found that there was difficulty because of contextualizing it in terms of our nursing care and also who's going to help this patient when they ambulate. So in our protocol, we keep it for 6 hours. Then after 6 hours, then the catheter is removed.
Thank you very much, Dr. That's the question I wanted to ask also.
Oh,
By the way, thank you. I must congratulate you for what you have done and how brave you have been to change the attitude in your people. And also for your people to believe in you. I have two things I have a problem with. Long ago, if you look at me, I am on the 6th floor. And when we were being taught to use chlorhexidine, we used to use iodine initially, but then changed to chlorhexidine. Now, it is back to chlorhexidine. I mean, we used to use chlorhexidine, then iodine, then back now to chlorhexidine. I don't know which one is which. Two, the issue of saving. Shaving, I thought we were told, you know, you get a lady who has never shaved since she started, since puberty. And then now this is the prime predator. And you want to cut through on that hair. Are you sure you will be safe as far as hygiene is concerned? Two, how will you apply the dressing? Through the bush?
Short, Kimani.
So chlorhexidine, again, robust evidence from a Cochrane review that chlorhexidine is superior, and there is biological plausibility. As we mentioned, it is not inactivated by blood, organic products. It has a higher residual of action. So that usually is what is recommended. And that is what has explained that transition. Now, shaving, based on the evidence, there is increased risk of SSI. So in my view, the discomfort of having to make an incision through the bush and having to put the dressing over a bush, if I weigh, I would rather the patient not have an SSI, at least based on what the evidence says. Studies have also looked at role of shaving before, like the night before, and it's actually been shown that it's still not, not effective. So, so for us, we don't shave. Yeah.
Yeah, Gadoga has a burning question.
No, it's not a burning question. It's just a follow-up to the question that you've just answered. The recommendations are that you don't shave, right? However, in the situation that you have to shave, what is recommended is using an electric shaver, a clipper, because that one doesn't cause the micro injuries that happen when you're using a surgical blade, which then acts as a conduit and an entry port for microorganisms. So if you really have to, then you use an electric shaver or a clipper.
Excellent. The catheter part, in Kegumo, we actually retain a catheter for some time, 6 to 8 hours. And the reason for that is because sort of early mobilization increases spinal headache. So we actually use a catheter for prevention of spinal headache. You know, one of the causes of spinal headache is actually sort of waking up or sitting. But anyway, we'll discuss that in that forum of yours for where we'll bring it. Then we can discuss whether that is a real thing. Thank you very much.